in a long run time. The more important catheters for aspiration thrombectomy in this list are the export and the Pronto catheters. Those are the two catheters which we often use in the cath lab. Mechanical thrombectomy devices, angiojet, we all know about angiojet. It's a rheolytic thrombectomy system. It infuses saline in a high jet which dissolves the clot, and it's suctioned out with the same catheter. This is a case where there is a thrombus in the very proximal LAD and also the mid LAD, and the second picture shows a thrombus being aspirated by the aspiration catheter. Following aspiration, the lumen is restored, but there is residual stenosis, and there is no occlusion. Distal embolization happened, and there is occlusion of the distal LAD. And the patient was put on 2B3 receptor antagonist and bivalirudin, and PCI with drug-eluting stent was performed in the proximal LAD, restoring the flow into the distal vessels. This is a picture of the red thrombus, which is aspirated from this case, and this is another sample of white or a platelet-rich thrombus from another patient. Now, the data for aspiration thrombectomy, there are multiple studies, smaller scale studies done, and in 2013 there was a meta-analysis of all these studies showing that there was some benefit in reducing the major adverse cardiac events and also all-cause mortality. But the largest of these trials was TAPAS trial, which showed that there was mortality benefit in doing aspiration thrombectomy as a first primary therapy in patients with acute ST elevation MI. However, reinfarction, target vessel revascularization were not different in both the groups. So the comparison was the conventional primary PCI as a control, and aspiration thrombectomy was a treatment arm. The stroke was slightly increased, however, it was statistically non-significant. Mechanical thrombectomy, like an angiojet, the results showed there was no difference in major adverse cardiac events compared to conventional percutaneous coronary intervention. The all-cause mortality was also similar in both the groups in the meta-analysis. The reinfarction and the target vessel revascularization was not different at all in both the groups. The stroke, there was slightly increased risk of stroke in patients who underwent mechanical thrombectomy as a primary therapy. So there are three important thrombectomy trials. The TAPAS trial, which showed that there was an improved myocardial blush grade after percutaneous coronary intervention, and also there was a reduction in mortality. But however, the Scandinavian trial, the TASTE trial, did not show any mortality benefit at 30 days and even at 1 year. The largest of the trial was published in New England Journal of Medicine in April 2015, enrolled close to 11,000 patients in multi-center trial in different geographic area, Europe, Asia, and as well as US, which compared routine manual thrombectomy to primary PCI alone. It showed that the routine manual the thrombectomy as a primary treatment modality did not reduce the risk of cardiovascular death, recurrent MI, cardiogenic shock, New York Heart Association class 4 heart failure at 6 months. But it was associated with an increased risk of stroke in 30 days. So this was a Kaplan-Meier curve for PCI. The first graph is a primary event, primary outcome event. There was no difference in both the arms. The second graph down is the stroke risk, which was significantly higher in the aspiration thrombectomy group. In another study, there was data showing that maybe in patients who present later, after 6 hours, 6 to 12 hours, the reperfusion rate, if you use thrombus aspiration catheters, may be better than those patients presenting early. So that is one way to look at it. If patient presents late with a high thrombus load, you may be able to achieve better angiographic results by using thrombus aspiration catheters. So in effect, those patients who has low TIMI flow, TIMI 0 or 1, with a high thrombus score of more than 3, after a primary treatment with balloon angioplasty, so balloon angioplasty should be the primary therapy. After balloon angioplasty, if you still have thrombus load, it is appropriate to do a manual thrombectomy and repeat if needed. And if the vessel is 3 millimeters or more, that means it's a large vessel, in presence of high thrombus load, you can try rheolytic thrombectomy, that's angiojet aspiration. Thank you.
Okay.
Thank you.
Thank you very much, Professor Koshi.